respectful of time, and all of your panelists are here, so.
Fantastic. Thank you so much, Shelley. My name is Dr. Kim Yu, and I am the moderator today on our webinar Zoom panel with the CAFP. And we have with us 8 amazing family physicians and physicians from around the state who will be talking to us today about COVID, their response, and what it is that we can do to really impact healthcare in the state of California, especially during this COVID pandemic. I would like each one of our panelists to introduce themselves. And so I'm going to ask you each to just give a few moments and to let us know who you are and tell everyone who you are. Hey, Hobart. I have a big picture of Hobart on our screen, but I'm going to ask Jeff. Dr. Luther.
All right, I'm Dr. Jeff Luther. I am a part of the full-time faculty of the residency program at Long Beach Memorial Medical Center in Long Beach, California. And what else did you want us to say, Kim?
Maybe what you do at CAFP or what you have done very briefly.
Sure. Through CAFP, I'm a past president of the Academy, and I serve as the senior delegate to the AAFP. In my day job, I'm director of health policy for our residency program. And right now I'm just working along with all my colleagues trying to figure out how to continue to train the next generation of family physicians in the midst of a pandemic.
Fantastic. Thank you, Jeff. Shannon?
Hi, everybody. My name's Shannon Connolly. I am the Associate Medical Director for Planned Parenthood of Orange and San Bernardino counties. And then I also run our 7 primary care clinics, and I am your speaker.
Awesome. Janine?
Hi, everyone. I'm Janine Rodems. I have been a previous director on the board for the CAFP. I'm president of the Santa Cruz Monterey newly joined chapter, and I am presently in a direct primary care practice with 1 other physician. So we're in a small practice environment.
Fantastic. Thank you. Paul?
Yeah, thank you. I'm Paul Papanek. I'm a physician with Cal OSHA in the Cal OSHA medical unit. I'm also, I should confess, a lapsed family doctor. I let my boards go after I think my 6th recert a couple of years ago. And I'm so grateful to Shelley for inviting me to join you up. Just wanted to talk a little bit about a Cal OSHA standard that affects COVID-19 treatment.
Thank you. We really look forward to hearing about that. Jay?
Hi, good evening. My name is Jay Lee. I am the Chief Medical Officer for Share Ourselves. We're a community health center network here in Orange County, California, where as of 2:51 this afternoon, the county health officer basically shut everything down. So really pleased to hear that. I think it's the right move to make, very brave in a county that doesn't always get science. I'm looking forward to participating. Regarding my past involvement with the CAFP, I too am a past president. We should call me President Eject. I think that's what we like to call ourselves. And currently I serve as the president of the Family Physician Political Action Committee, which is involved with ensuring that family medicine's voice is heard in Sacramento. Thank you for the invitation, and I'm so grateful that we have the opportunity to convene in this way, albeit really hard not to hug all of you or give you a high five, but we can do so virtually.
A virtual one, Jay. Thank you so much. Who else do you have? Trudy?
I don't think Trudy's on yet. She is in clinic, so
okay.
On her way.
And who am I missing?
Julie.
Julie, are you on?
Julie's here.
Yeah, I'm here.
Awesome. Do you want to introduce yourself, Julie?
Sure. I'm Julie Wood. I'm a family physician. I am on staff at AAFP. I'm Senior Vice President for Health of the Public and Science and Interprofessional Activities, and helping lead our COVID-19 efforts at AAFP. And pleased to be here to talk with you about that tonight.
Thank you so much. Did I miss anyone else?
Me.
Jasmine. Hey.
Hi, everyone. I'm Jasmine Baines. I am a governor-appointed commissioner on the California Healthcare Workforce Policy Commission, charged with guiding and directing healthcare workforce in California, and practicing as a full-time family medicine physician in Taft, California, which is a rural FQHC. There's no hospital. Our closest hospital is about an hour away. I'm the only physician at my FQHC. I'm also the medical director for a rehab unit in Bakersfield, which we actually had to send a patient today to the hospital for positive symptoms. So I would love to hear feedback on what I should be doing for quarantine from everyone here. And then also I serve on the Developmental Services Task Force of the state of California.
Thank you so much. So much experience on this call, and so I want to make sure that everyone has a chance to say their piece, and also for some answer question time afterwards. We have some slides. I don't know if we're able to show them right now. I want to just give a brief overview, and then we're going to launch straight into everyone little snippets of information. And so our first slide is actually, I'm going to see if it comes up. It's a slide that actually overviews the information.
Can everyone see my screen? It has a big map of the states with all different shades of autumn.
Yeah.
Okay, you're good to go, Kim.
Great, awesome. I guess I'm not seeing it. Okay, there you go, I see it now. Okay, so we have our states reporting cases, and as you can see, our total number of cases in the US is over 4,000, and in the state of California right now, we are at 472 positive tests with 11 deaths, and you can see the breakout in terms of ages. There are children that are getting COVID, so we have 7 cases in under 17s, and over 18s, 300, and in the elderly, 100. I have a little bit of an echo. Do you have an echo? Hopefully not. Next slide. The other information that you can see is that we have got about 21 labs from state public health labs that are testing. Obviously, there are private labs like Quest and LabCorp that also are testing, and others that may be on the way. And I wanted to just give an overview just from the information that is being shared by the California Department of Health on the areas with community transmission. And I know that for many of you, you're like right in the thick of it. I know because you've messaged me, and I'm hearing from physicians from around the state, around the country, about how the situation is for them, whether they have testing or they don't have testing, whether they're able to do testing, and whether they have PPE. And so these are all issues that are tremendously, I just can't even begin to tell you how much it really has struck me, how we have been sort of like hit from the side and swept over from this COVID pandemic. Next slide. And there were many different topics that came up when I was thinking about, what are we going to say? How are we going to say it? And so for all these different topics that are here, I've asked several of our speakers tonight to really give us their thoughts. And so the first one being Julie from AAFP. The update from AAFP, we've seen some amazing work that they've done, some amazing advocacy during this pandemic, and I wanted to hear directly from AAFP. So Julie, could you give us an update of what's been happening?
Sure, I'm getting some real-time stuff right now, so I may be a little scattered, so I'm trying to get the exact things. We just put some things out this afternoon. One thing I wanted to let you know is Doug Henley will be on a call to the White House tomorrow with Vice President Pence. And I sent a letter that we have ready to go to send to complement that. We interestingly do not know what the topic is going to be other than COVID. What we're going to be asked to talk about, it's with some of the other medical organizations, and they've been pretty quiet about what they want to talk about, but we have a lot to say. If they continue to say they think they're doing a good job, we're not going to back that up. So I sent the letter out to Kim right before the call, so she can share that with everybody, or I'm happy to send that to any specific email. We'll be posting it. But the main foci of that letter will not surprise you, will be to continue to advocate for adequate PPE for everybody, to talk about the major concern around testing and lack of testing, sporadic testing availability and so forth, as well as advocating for proper payment, telehealth issues and things like that, which I can go into more. I want to make sure everyone knows about our resources. Hopefully that most of you have seen them. If not, we do have a site right off of our front page of our webpage that basically collates a lot of the things from the CDC, so you can find them very easily. We have a community that's a member exchange for peer-to-peer sharing, as well as staff is regularly on there to answer questions. And it's up over 400 members now, and it's quite robust. And we're very thankful for that. So if you have any questions about that or concerns, be sure to let us know. But we are learning from it and learning what we need to do to help you, as well as members learning from each other. So we got that up pretty quickly, and it's been, I think, very helpful. We have information that went out today in an email to all members and to chapters that has Sean Martin's newest blog that has a lot of updates on advocacy. And you'll see particularly new updates on payment, coding, on advocacy around telehealth that I mentioned. We did launch a speak out this week, so I would encourage everyone in California and all our members around the country to use that speak out to reach out to your legislators, and it addresses those top issues that we're all concerned about, the ones that are listed here on the screen, particularly around PPE and everything that we're concerned about. So please use that speak out so you can reach out to your California legislators. We are working on, I do not have a timeline, Kim, yet. I did talk to some of the CME folks today. One of the things that happened is great, that we got outreach from the Critical Care Society that they are going to share with AAFP, their modules on critical care and COVID that they developed really quickly. We have heard from several members that they're worried they're going to need to beef up their hospital skills if they're called to work in the hospital and help take care of critically ill patients. So we do not have it up on the website yet. They're getting us all the information, and we'll be sure that all the chapters have information on that as soon as possible. So we're really excited about that, and that was very amazing of the Critical Care Society. So more to come on that, and we're continuing to develop a series of webinars that'll be rolling out over time. I don't have the dates yet on that though, but our CME folks are working on diligently on that. I'm trying to think of other things I wanted to share with you. Specific things you want to know? Oh, one thing that came out today, we did update our checklist, and I've got specific things that are in there. So we early on had a checklist to prepare the office, and we've continued to update that. So things that are in that, I'm going to actually read this one off. We updated triage and patient flow in the checklist because things look a little differently now than when we first created it. Also non-urgent visit guidance, a lot of questions that have come in on that. Also suggestions that have come in through the discussion board. Referral and transfer of patients. And then one of the things we get a lot of questions on, as you can imagine, are definitions of self-monitoring, quarantine, and isolation. So that's in there, as well as waste disposal, and as much as we can with the limited guidance we have on equipment and supplies. So those were updates today specifically. A lot going on around advocacy behind the scenes, some that you're seeing very overtly and some that you're not. But we're going to keep it as out there as we can, and we need lots of help and lots of grassroots. So please help us get the voice loud, and you guys are doing a great job.
Yeah, we're trying to get the message out and tweeting, retweeting everything that's coming out from AFP. And we want to make sure that everyone is joined up and signed up for the AFP community on COVID. So if you haven't signed up yet, please do go to the community and join the conversation there. Thank you so much, Julie.
Thank you.
Does anyone have any questions for Julie?
I see Jeff.
Hey, Julie.
Hi.
Any questions? Give a second. And if not?
They may come up as we go along.
Yeah, make
Okay.
them.
I'll be here.
You'll be
And
here?
feel free to email me. I'm doing a lot of emails. Emails and phone calls.
and messaging. So
Mhm.
thank you so much, Julie. Thank
You're
you.
welcome. We're
Now,
all together.
yeah, we all are in this together. That's for sure. Thank you. So PPE, let's move on to PPE. I've heard everywhere that we don't have enough. And so I wanted to hear from Paul, you know, what's OSHA got to say about all of this?
We thank you so much. This is just a terrible problem. Let me take a step backwards. I don't know, Shelley, do you have my slides up that we can show on the screen?
Yeah, let me see. Keep talking while
Yes, we can. Sure, I will. So Cal OSHA has a standard called the Aerosol Transmissible Disease Standard, and frankly, if anybody on this call has actually read it through, I'm going to give you a prize. It passed about 9 years ago, and the reason why Cal OSHA passed this standard, which no other state has, this is unique to California, is because we realized, along with the health department, that no existing OSHA standard, and they're designed, of course, to protect the workforce. So workers, our philosophy is workers cannot get sick doing their job. It's not okay. But we realized that no other standard really protected the airway. This is this complicated rigmarole, and it is complex. That's designed to find those circumstances where airways are the path to infection and try and cut that off. And the next slide. So this standard passed, and my sense is that Cal OSHA has probably not done as good a job as we could telling practicing physicians about this. My sense is hospitals, emergency rooms, paramedics know about it, public safety officers. And I'm not so sure that primary care physicians in particular know about it, and it does apply to us, to our colleagues who see patients who may have an infectious disease. The next slide, in particular, it specifically mentions when the health department calls out a novel pathogen like COVID-19, then the standard applies in that situation. So family docs, internal medicine docs, urgent care clinics are in. Now, there is an exception for physician offices. If your practice just says, we don't see people with infectious diseases. I mean, if you come in with a chest cold or a COPD exacerbation, we're not going to see you. And then the standard does not apply, but you still have to do a couple of things, which are in that box on the bottom. You still have to train your staff to identify a patient who presents as potentially having disease. And ordinarily, I would say, most of us may not be doing that in our practices, although we really should. And Cal OSHA, if we were to come in and do an inspection in a doctor's office, and we do those from time to time, if we walk in and ask the receptionist, and say, just pretend I'm a new patient and you see that I'm coughing and I'm feverish and I look pretty bad, what would you receptionists do? And the right answer to that is, well, I would call somebody to do some triage if I don't know. Or if we're going to see you today, I would ask you to put on a surgical mask, and I'd tell the next person downstream taking you back to the room to put on an N95 mask. And we put you in a room, close the door, and we keep you from infecting anybody. That's the right answer. So if your office doesn't have that answer, if your receptionist can't do those things, that's a problem. Now, the next slide is, so who has to do this? And the fact is, if you have a patient who presents and you have a reasonable suspicion, and there's some legal wiggle room there about whether the patient has a COVID infection, you really do have to do all of these things. Well, before even you do that, it turns out if you're a family practice office, you have to have a written plan. It doesn't have to have a ton of detail in it, but it does have to cover the fact that you have a schedule for training your staff about this, that somebody in the office is responsible for purchasing and replenishing your supply of N95 respirators or surgical masks for the person to wear. Somebody's responsible for, if you get a reportable disease, who calls the health department and lets them know. All of that is in there. And of course, for those who have to wear a respirator, an N95, and that's almost anybody who's these days who's caring for, well, I don't have to tell this group, if you're caring for one of these patients, your airway needs to be protected. And Cal OSHA, and frankly, federal OSHA as well, this is to me just a troubling thing. You may be aware there's sort of a fist fight going on right now between OSHA and CDC. CDC, I think, partly because they recognize that there's this terrible shortage of respirators, that says, well, in many outpatient settings, we don't think that aerosol transmission is so important. It's really droplets. So Cal OSHA and just federal OSHA yesterday announced the same thing. They said, for purposes of OSHA enforcement, healthcare staff will have their airways protected if they're treating known or suspect COVID-19 patients. So if you do that, that means you have to have then a protocol for fit testing people and training them about how to use it. You can't just hand somebody an N95 and say, there you go. Someone who knows about how these things work has to sit the employee down and tell them some things about how to use it, how to check for a tight seal, squeeze the little thing over the top of the nose. So now the big question is, we know that if you go on to, a procurement site, Amazon even, you can't get N95s anywhere. And I will tell you, I was on a phone call till about 6:30 tonight with a bunch of folks saying, how are we going to handle this? It is in my view, just an utter disgrace that we don't have enough of these things to protect America's healthcare workers. And what's the backup plan? Well, if you anticipate caring for a patient who has COVID, I mean, I know this is going to sound extreme, but you have to go buy, a regular industrial respirator. So this is called an elastomeric respirator, and they come with this soft, squishy plastic, and you can, screw a couple of cartridges onto that respirator. That will filter out respirable sized aerosols. And I will tell you, I mean, I didn't know when I joined Cal OSHA 8 years ago that you could do your job wearing these things, but now that I've had to do this for a long time and been on tons of inspections and had to, go through my day wearing respirators, they're not fun, but you can do it. And if you're only going to be using it for, let's say, 10 or 15 minutes to take care of a patient, you can do it, and it's going to protect you. And I suspect that is the answer, because it's as tough as this is to say, it's not okay to have our nurses and front office staff and our medical students and residents exposing themselves to COVID. If you decide to use a respirator, we have some other rules that have to do with, you got to clean them afterwards, and you can dunk them in detergent or bleach, and unscrew the cartridges first, and then just let them drip dry, and it's fine. And so there's some learning to do if you decide to use a cartridge respirator, or these cappers or pappers that maybe some of us learned about during the Ebola days is the other alternative. Cal OSHA just today approved a new set of just do's and don'ts for medical offices, and that just got posted on our website, and I will share those links with Shelley, and I'm so grateful if you all could put that on your website, and I'll make sure that Shelley also has contact information for me, and for Cal OSHA has what's called a consultation unit, and any employer in the state who says, I'm not sure I get what you need me to do, please call us. We would much rather have a conversation up front rather than get a complaint from an employee and then have to write you a ticket, which we do, but we'd rather do it with the carrot instead of the stick. So with that, I'll stop and see if there's questions. And
yeah, we've got two questions.
Yeah.
So one of our questions is, in areas where there is widespread community transmission, is there any value in universal precautions, sort of both surgical masks for source control and masking healthcare personnel, or is that just wasteful of PPE? Shannon says, I'm concerned about asymptomatic viral shedding in the community, but want to balance preservation of a scarce resource.
That's absolutely right. So this is really the thorniest question, and you probably know that we have not really been able to get CDPH to give us a clear statement. They're sort of sticking with their 3 feet or 6 feet. So I think if you're walking around in social distancing, the likelihood of an aerosol exposure in a non-crowded place is pretty small. But if you're in a place that's crowded and you really can't keep a distance, as you maybe other speakers will talk about this, we now know that from day almost 2 of infection, even if asymptomatic, the pharynx is teeming with virus. And we've seen the study in the New England Journal that I think just came out today that says that if a COVID patient produces aerosol, that's an if, but we think that there's some evidence that they do, that virus remains detectable and probably viable for at least 3 hours in the air. So not quite as bad as measles, but which will stick around for the rest of the day, but bad enough.
Okay, thank you so much. We're gonna move along and we'll come back and circle some more about this PPE, because I know Keisha's asked a question here about, if a practice is completely out of PPE, are there any alternatives, not necessarily a bandana, but or should they just turn away patients until they could get it? Because a lot of our docs are just using a surgical mask. And if you're saying now that they have to go get one of these respirators, it may take several days before they can get access to one of those. So should they be just not seeing patients?
Yeah, I think that's absolutely right. Our grouchy advice is that if you can't be sure that you're safe and your staff are safe, then you cannot be seeing these patients. And so I wish I had a better answer for you, but I think that's the right answer and the best answer.
Okay. I'm gonna ask, Jasmine, what are you doing? Tell us what's happening where you are.
Sure. So Taft is a very small city. It's isolated as it is, and when a city like that is told that you need to isolate even further, there's a lot of mental health repercussions that happen from that. So a lot of anxiety, a lot of people that feel that it's the apocalypse, and a lot of people coming into the clinic just because there's mass hysteria, and it happens a lot in cities that are very, very small, as well as big cities, of course. So a couple of things that I did in the clinic so far is I've separated. We have to do as much as we can to decrease risk of exposure. So the first thing I did was I separated our waiting room into healthy and sick side. And then also our rooms inside, we have 2 wings of rooms. So on one side, I have my healthy patients, and then on one side is my sick patients, anyone with a cough. Again, of course, if you cough, that can travel across, yes, but we have to do what we can to organize our clinics as much as possible. So, and I've been trying to tell people as much as possible for the next 2 weeks, let's minimize the physicals, let's minimize the pap smears, especially for the next couple of weeks. But there are people that need to come in and get seen. So we do what we can. I have an isolation room that's close to a back door that's going to be my testing site for people that if they call in triage positive for symptoms of the virus, they'll come in and they'll be triaged and tested in that room. Couple of other things is checking in with your staff, because the problem is a lot of my MAs have kids at home. Now kids are not in school, so they're stuck. They don't know what to do. They have to be at home to take care of kids. There's no one there. So workforce in the clinic is a problem. But working with the staff, making sure they're okay, because staff is just as much hysterical as providers, and I'm really disheartened to see that there are quite a few providers that have decided to not see sick patients. I think, we need to really reassess ourselves, why we went into taking care of patients. The fact that any provider would say, I don't want to see a sick patient because I don't want to be exposed. I have kids at home. I understand their concern concerns, but at the same time, you were a provider. You took a Hippocratic oath to take care of people, and in times of need, you're asking to rise up. So that's unfortunate that I see that, but I do see that. Other steps is making sure with my staff that we're getting enough sleep, that we're getting enough exercise, getting our immune system up. I think, you know, it's no secret that the healthcare workforce is going to be strained overwhelmingly over the next 2 weeks. So we have to take as many precautions on our side to make sure our staff is protected. And yes, I agree. If you don't feel comfortable having the proper amount of PPE, don't be seeing these patients, because if you're exposed and the clinic has to shut down and you have to be quarantined, that's a doctor off the books that can be seeing patients. So you have to do as much as possible to take care of yourself, and do as much as to take care of your staff. I think those are steps that we're taking right now. I've upped the lab. I make sure that we have our testing kits in case we need to test anyone. So far, we have not had to. Rural towns, the congestion is less. I think it'll remain a low risk, but being prepared shows the public that, you know, it helps control the hysteria, because it shows them that they have a proactive person that's coming here and trying to, you know, make proactive measures. I just came back from the city council, so I reached out to our mayor, our city council, spoke with them, like, you know, make sure that they can address the public appropriately. And I have full support from them, so I was able to go do that. So as a physician, reach out to your council, reach out to your mayor, make sure that they understand where you're coming from as a physician. This is the time to show that physicians need to be leading. You know, a lot of decisions are made that by people that are not physicians right now, and that's making the hysteria worse. We've trained for this, we've prepared for this, we are the most equipped to handle this, so we should be there making those decisions and leading. This is our chance, so step up, people, please.
Rock on. That is a perfect segue to having Lisa Fulber from our CAFP CEO to give a few words and update from the governor.
Sure. Hi, everyone. Thanks for being on the call. Can you all hear me?
Yes.
Okay, great. So just a quick update. The governor had a press conference today, and I would say all in all, not great news. He did not commit to, although he implied that schools, it's likely that they will not be back in session until fall. So I know for a lot of you that have staff that are juggling kids at home, and for, you know, those of you who also have kids at home, that can be hugely problematic in terms of even more to try and balance. He talked a lot about making sure that folks weren't kind of put on out on the street, and having some legislative protections for renters, for example, service workers who aren't able to pay their rent. He talked a lot about working with hotels where they have a lot of capacity right now, trying to house unhoused people who are at risk. He talked about some changes in Medi-Cal. The state will be applying for a number of 1135 waivers. A lot of that will be around providing telehealth services. So for example, in FQHCs, getting a federal waiver to waive the face-to-face requirements so that FQHCs can do more virtual. The state will be applying. I don't know how that will be received at the federal level. Also talked about reimbursement for off-label use of medications and trying to get a waiver. And of course, this would all be in the Medi-Cal program, but hoping that commercial insurers will kind of see that and take some lessons there. The legislature, I think it was yesterday, although the day seems so long, they adjourned until mid-April, which is huge. I can't remember the last time that that's ever happened. And so they basically adjourned, gave the governor up to $1.1 billion in discretion to spend on COVID-19 related expenditures. So he has authority to do that. And, you know, just really a lot of day-to-day with the governor at the press conference included CMA's CEO as well as the Hospital Association CEO, and a lot of discussion and questions from press around bed capacity. So that was also something that is certainly on the minds of everyone in state government. That's really sort of the summary. So that means that all legislative hearings have stopped. There is still some regulatory work that is happening, including all of the work around trying to get these waivers in place to apply to the feds to do some of the telemedicine, telehealth work that needs to happen, and looking at those federal waivers as well as making some changes, working with the insurance commissioner and figuring out how those the state of emergency basically allows a number of changes to be enacted, including around scope of practice issues. But there won't be any legislative action. It will just be at the regulatory level.
Awesome. Thank you so much, Lisa. There's a question here. Has California announced that we have reciprocity in our medical license with all other states to assist in telemedicine?
I have not seen that. I don't want to say definitively, but I have not seen that. That hasn't been something that has been shared with us. So I'm going to say probably not at this point. I don't know what the conversations are around that, but if something changes, Dr. Reed, we will make sure that our members are aware.
Right. And Keisha's exactly right about FaceTime, Skype, and Messenger and Google Hangouts are all expressively okay per the lightened regs that came out today. And we have Dr. Galdamez saying they're using Zoom, which is awesome. We love Zoom. We're using it right now. Just checking back in some of these questions.
Kim, we will add all of the links that Julie and others are adding to our resource page for you.
Fantastic. Thank you so much. I wanted to reach out and get Jay's perspective, especially when it comes to sort of the special populations. And you have a new job. Congratulations. And you're closer to me now, which is really exciting, in South Orange County. And so, Jay, can you tell us a little bit about what's been happening? And this week, I remember I reached out to you because I saw your site was actually listed as a place that was doing testing. And I was like, is Jay doing testing? And so I reached out to you and tell us what's been going on with that.
Yeah, let me respond specifically to that first, but I'll provide some context. So Kim is correct. I started a new job on March 2nd as Chief Medical Officer for Share Ourselves. I walked in the door at 8 o'clock, and at 8:02, my CEO said, "So, welcome to the job, COVID-19." And we kind of went from there. And, you know, basically they've not had a Chief Medical Officer for about a year. And I got to work right away to start putting some plans together. We, a lot of the same things, you know, echoing Jasmeet's experience, just kind of building out kind of like a command center sort of thing. So, because we have 5 different clinic sites, just needing to get data and information and inventory and messaging and communication out to the staff. As many of you know, Orange County is the 6th largest county in the United States, yet we do not have a county hospital. And also, I think the sort of public opinion or public perception of Orange County that it's a well-to-do county. But the truth is there are pockets, large pockets of population that are immensely underserved because of the lack of a county hospital and because of the sort of, I guess, the peppering within the county of community health centers that serve the vulnerable. Specifically regarding the HRSA issue. So there was a social media post that said, oh, hey, if you want to get tested, you should go to your HRSA FQH, go to the HRSA website and look up your local FQHC, and you can be tested. And we started to hear about this sort of mid to late last week, not knowing where this was coming from, because the truth is no one sent us things. We had to be proactive and actually go out and get the testing kits, and also ensure that we have adequate supply of PPE. Turns out we have a storage room that's sort of like the room of requirement from Harry Potter, that where we found some additional PPE and masks and other things. So, we try to get ahead of it. Actually, Kim mentioned the tweets. We really wanted people to know that we're happy to chip in, but we're also under-resourced and we need help. But at the same time, we're happy to try to meet people's needs where we can. So, needless to say, that's an evolving story. We have what we feel is sort of sufficient amounts of testing kits and PPE to do a small batch of focused exams. But frankly, the spidey senses, my public health spidey senses are like, we need to get to global testing, and why the hell aren't we there yet? So I'm just going to put that out there. Specifically, one of our sites is one of the larger homeless shelters in Orange County. We have 200 patients that we treat there. It's very hard to achieve the 6-foot barrier between people to do the physical distancing. The isolation room is basically 5 cots that are about 3 or 4 feet apart. And the staff in the shelter are not clinically trained per se. So we have the clinic upstairs, and then the downstairs folks are not exactly clinically trained. So they've been looking to us for guidance from a shelter perspective. How do we prepare ourselves best? Because we're really technically only there about 2 days a week. So, as you can imagine, there's a lot of challenges. Quite frankly, with the county and with other agencies, we've been very clear and loud. Everyone in the shelter needs to be tested, or this is going to be a public health disaster. And sorry, I'm getting a little emotional. All right, a little tired, so my barriers are a little bit low here. I need like a mask for crying. So in any event, this is going to be a public health disaster if we're not on top of this. So we're continuing to try to advocate and put pressure on the county to act. I think it was very encouraging today that the county recognizes the issue here, and they did call the emergency health order to basically have everyone stay at home except for essential services. Right. So, I think our task as we evolve here is not only take care of the patients who are coming to the clinic, take care of our staff, because our staff had the same concerns that Jasmeet's staff, in a different part of the state have stated, and then really special population perspective. We really have a moral obligation to take care of these folks and not put them in harm's way. So again, really it's that advocacy piece as a family physician that we have to speak up. We can't just be passive and just be like, okay, well, I guess we can't get test kits, so we'll just wipe our hands of this. Lord knows we're going to just continue to keep trying until we can get the right resources to folks, because everybody deserves this. And I will say that it's fascinating to me that what the conversation around universal health coverage is going to be after this experience as a nation. In any event, thank you so much. I really appreciate you convening this group, and I continue to learn from all of you in our different forums. And it's cool that we're all together. I think there's almost 40 of us on this call. So thank you so much.
Thank you so much, Jay. And I echo many of the thoughts here that are telling you how much we love you and appreciate you, and just thank you for your advocacy for your patients. And Dr. Reddy here has has been saying, you know, we are all sobbing at some point. I'm sure, I know I was yesterday. I think many of us have shed many tears past week. It's been a really rough week, and just knowing how many people that we could lose is really sobering and very painful.
I'd like
So,
to share something, if I may, Kim.
sure, Dr. Reddy, go ahead.
Yes. So, you know, aspects of what each of you are dealing with in my practice, so you don't need to hear those details, really winging it with, you know, how do we protect our staff? We're down to our last box of N95s that we purchased 2 months ago. Rather than send us our supposed allotment of 2 boxes a month, they have canceled every order on us. So that's why I put up these little comments about construction workers and dentists, and we're still working to figure out how to keep our office open. But I will share something that I'd asked Lisa not to, and at this point, without going into details, my name was put forward and I ended up on Gavin Newsom's task force for coronavirus testing. And 5:45 p.m. I get a text, and 6 p.m. I'm on this call, one of just about 10, 12 people, including the health departments, the Health and Human Services, etc. You can imagine. And they dropped off after the 2 calls and just went dark. CMA told me today that, and it was through CMA, through Alidade, that I was put on there as a physician representative. And I made a number of comments that simply was with this focus. I mean, I advocated, and that's why I wanted to share that, for our inability to provide care without widespread testing capability. And in the absence of that, that we should be talking about short-term limitations, but working with every resource possible for long-term. Can we do what South Korea did already? You know?
Right.
Can we follow that example of amazing responsiveness and widespread testing rapidly? And yeah, I thought it was just me that I wasn't called back, but it looks like the whole committee went dark because, you know, they're working on what they're working on.
Wow. And
I wanted
so,
to share that because, you know, it was pretty emotional to say, okay, what's going on now? You know, I'm supposed to have some idea what's going on, and I don't. So.
well, that's why, you know, Julie's saying right now, use the AFP Speak Out to U.S. legislators. And thank you so much for being on that committee. And I was really great. I was really glad to hear that you got appointed to that. I'm very sad to hear that it's gone dark, because at a moment like this, you'd think that they would actually want to continue. So that's kind of sad, to be honest with you. But I think it's important that we continue to advocate, continue to speak out, and really get to talk to every single one of our legislators about this, because we need to protect all the physicians and healthcare workers, so that we can do the testing. And if we don't get the test done, it's really like we're shooting in the dark. So yep, we need to get loud. Jeff, thank you so much. Sumana, thank you so much. Jeff, you want to give your perspective in terms of residency programs? We've heard stories from medical students and residents who are being told to stay home, and others where they're told no, they have to continue where they're at because they're needed. So what's happening for you?
Depends on the day. As of today, in residency education, we're constantly balancing our dedication to our patients and our dedication to education and teaching our residents and our medical students. And this is straining it in an unusual way. Medical students were sent home officially yesterday, as they are kind of is watching this webinar from Leawood, Kansas right now because his school in New York shut down, and so he left. Students are being put on hiatus all over. Our residents still have to learn, and they're worried about their personal exposure, but also their education. We adopted a policy last week that our residents would not be allowed to see patients who were COVID positive or suspected. And that means that as they see patients, either in the hospital or in the office, if someone has enough risk factors determined through triage or they test positive in the ER, that means that the team is kind of flipped and the attending is the only one going in to see the patient. And the resident has to help us with the EHR because they're better at it than we are. But we're the ones seeing the patients and the residents are observing from more of a distance. I have a little ambivalence from an educational standpoint about that, but I recognize the responsibility we have to them and their welfare. We already have 2 residents home on quarantine, along with a receptionist and a member of the nursing staff. So we're down 4 people in our office just in the past week, and we can't let that keep happening. So in terms of education, we're doing a lot of the things in the practice that other people are doing, canceling or rescheduling non-essential visits. The residents are learning a lot about telephone encounters, which is something the ACGME and ABFM want them to learn anyway. They're getting a crash course now, as many as possible. Our visits are being converted to telephone encounters.
32 minutes past. So let's turn it off. We finish it tomorrow. I told you.
Now I have no audio, but I'll keep talking.
You have audio.
Okay, I just can't hear anything else. But so we're doing a lot of the interventions other people are talking about. We have a screening tent in front of our building to screen patients coming in, and the RNs are coming back to the preceptor with concerning screens. And then I was realizing this afternoon that a lot of my day was making judgment calls. Yes, this resident can see this patient. No, you can't see this patient. I have to, or one of my colleagues has to. And so it's a lot of improvising, like everyone else is improvising, but in our own way. You know, Long Beach is fortunate. I think fortunate. We're one of 3 cities in California that has its own public health department. So we don't rely on LA County, which is probably beneficial given how widespread and huge LA County is. And the health officer for Long Beach is actually a graduate of our program. So a family doc we have a good relationship with. But they're strained, and they're encouraging us to, use our own discretion on testing and go through private testing labs rather than through the health department unless absolutely necessary. And the health officer was supposed to come give us a presentation yesterday, but she couldn't because she was just pulled too many different ways. So they got testing supplies. We can now do swabs in our office, whereas before we had to send our patients to the health department or to a local urgent care to get swabbed. We have currently enough PPE, but it's hard to know how much stock the hospital is telling us to preserve as much as possible. And listening to Paul's admonitions about not using surgical masks, I value them, and they make me that much more nervous about our supply going forward. But I think we're going to continue to do what we can for our patients and for our residents, because they have different but overlapping needs. And it's an interestingly parental role to find yourself in, which is what residency teaching is like to a certain extent anyway, but very much so now.
What about the residents that have to do like ICU month and, or they're on the floors doing inpatient or OB?
So yeah, a lot of the time they're on the floor, they're under our direct control, and that's fine. If they're in the ICU, the ICU attending, the intensivists have, because our policy comes from UC Irvine, which is our academic affiliate. So it's not just us, but all of the residents in the hospital are under the same regulation, except I think the pediatric residents, and that might have changed today or yesterday. So the intensivists know that the residents aren't going in to see the COVID suspects and COVID positive patients in the ICU either. And we have empowered our residents to make that clear to any attending. And if they have a problem with it, they're to give them the program director's cell phone and they can talk to her. So the residents know where they stand. And the problem is, we've touched on it a little bit in this meeting already, the devil is one thing, but who around you has the virus and we just don't know it yet. It's easy to avoid the sickest because they're obvious and someone else is taking care of them, but that's hardly a blanket protection.
We have a question from Dr. Reddy, and this is something that's come up for us is, physicians trying to understand the whole PPE thing. I have stories of physicians even saying that they're going to start sewing their own gowns because they can't get their PPE. But are you changing your PPE in between patients when you see them? Or are you kind of like reusing your PPE? I mean, I know that in Asia, I've got a friend who's a family doc in Asia who actually has a UVC light that they put on at the end of the day, and then they put their masks there to kind of zap their masks. So what are you doing with your PPE, and are you changing it out after each patient or reusing?
Well, in my case, reusing, not seeing, is in a typical, albeit busy family practice residency office where you're doing as many telephone encounters as possible. We're not seeing tons of people coming in highly suspect. We've had 6 cases in Long Beach as of yesterday. And like the patients I saw today, I saw some patients that were just normal follow-up on other things and not at all respiratory. And I saw a couple of respiratory patients who were sort of for low concern going in, and they were not concerning enough to test. And I still changed my PPE, but I'm using a conventional surgical mask, so I'm not burning through N95s left and right. And I think that's the case throughout my office. I don't know how other people are handling it.
Anyone else want to chime in there? How about Shannon? Shannon, what are you doing?
Well, when we first became aware that this was going to be a huge problem, we evaluated our own PPE supplies and came to the determination that we do not have adequate PPE. We are missing gowns and masks. I think our entire organization has a few boxes of N95 masks, and we're rapidly running out of surgical masks. And we don't have enough gowns, so it quickly became apparent that we weren't going to be able to adequately protect all of our staff and see sick patients. So we stopped seeing sick patients, which truly breaks my heart as a family physician. And we are focusing all of our attention now on building up telehealth capabilities so that we can continue to serve these patients, but without the risk of exposing our staff. And we kind of softly launched telehealth today and had a few encounters, and I think we kind of got a general sense of what it's going to be like. And tomorrow we've opened up a number of provider schedules. And we already have a waiting list, I think right before I got on this call, I looked and there were 78 patients waiting for a telehealth appointment. And I kind of went through what types of things they were waiting for. And they are deeply urgent things like I'm pregnant and I'm bleeding, or I have trouble breathing and I have a temperature of 103. I mean, there's some things that I'm just pulling off and I'm just calling those patients and taking care of them. But that's really been our strategy. And it's so disappointing because, you know, as primary care providers, we are the ones that know how to take care of these patients. And I want to be face-to-face with these patients and, you know, and provide that care and just the personal service. And it's not possible. So telehealth is where it's at. For our practice, I hope within a week to really scale up telehealth significantly and to be able to do several hundred visits a day. And hopefully our equipment and our IT department and our EMR will all work out and we will be able to hopefully achieve that very soon. In the meantime, we are kind of protecting our PPE supplies to be able to provide a few very core services that are really core to our mission. Of course, we're Planned Parenthood, so abortion services are really important, and we don't anticipate that there's going to be any other communities, like community type abortion services. And so we're trying really hard to figure out how we can maintain that service line and try to move almost everything, if possible, to telehealth.
I know that a lot of people are moving to telehealth, and that's something that many physicians around the country are really moving to. That there are different platforms that people can use. Someone started telling me that they started using doxy.me. Unfortunately, it was down for a couple of hours yesterday. But you know, I think it's definitely something that we all need to really look into to prevent people from needing to come in, especially our elder patients. Have any one of you implemented policies regarding your older patients when it comes to preventative care or their annual wellness visits or their physicals, any of that? Janine, you want to tell us what's happening with you? We're gonna have to unmute you.
There we go. There we go.
Thanks.
Yes, well, in our county, we got the order to shelter yesterday. So we have actually canceled all of our routine and regular care for non-urgent issues in the clinic. We are still reaching out, you know, as a DPC, we have the opportunity to be able to actually go out to homes if we need to. We still have a few patients in some of the assisted facilities locally as well. So we are trying to keep connections and communication with the family members as well as the staff of those facilities. We've only had to go out to a couple. My partner has a couple people who won't go into the hospital but have issues with heart failure, COPD, diabetes that we do need to tend to. So we are trying to do a little bit of in-home care on top of the triage and telemedicine that we've been doing. We are still seeing patients. We had to take a cast off today. We've got, some of the regular urgent stuff that needs to be dealt with. We are sorting patients by phone before they hit the office door. We've got signs up outside the office door for doing the triage and not allowing anybody in the office with any fever or sore throat or any of the criteria. We do have an area of isolation in the office that we've set aside, but the one case we had today where we had to do testing, we did it at the car door. So we've got a crash cart and a garbage cart that we are taking to treat these patients and be able to see them and to tend to their needs. But it has been very difficult. We're in a county that has no testing. They have very limited county health. They focus their care and testing at the hospitals level and have pretty much left it to us to use what's coming through Quest and LabCorp to be able to do what few tests we've been able to get a hold of. So then there's no tenting or anything really that's set up in order to do any community testing. And in fact, the tents that did get set up outside of our one hospital here were actually damaged in the rains that we had this weekend, so they're not functional. So we're kind of trudging through as we move into this thing, and I think as we're all feeling, it's only going to get worse.
Mm-hmm. Mm-hmm. Those rains were something, I know, because I started getting rain coming through my roof, like through the ceiling in one of my rooms. But that's not good to hear that the tents have come down near where you are. There are other physicians around the country who are doing drive-through testing, and they are asking people to, call ahead. And then if they are mildly symptomatic, that they would actually go to their car. They would come through and they would test them at the car rather than having them come to the office to infect their office potentially. And so that is something that many people are trying to implement throughout the country. Prasanth has a really great question here. I'm very worried about my otherwise sick patients who need to come for their follow-up exams. These are not routine visits, and these are not likely to be televisits because they need palpation, auscultation. Are you all asking such persons to wear a mask apart from hand sanitizers, or what are you doing with your sick patients that need to come in for their follow-up exam? Anyone want to take that? I'm going to ask Jeff.
Why did I know you were going to say that?
Because you're an ex-president, right?
Right. So we're still having them come in. We're not requiring masks if they're not symptomatic from a viral standpoint. If they're coming in for their CHF and COPD and diabetes and hypertension, you're right, we can't do those adequately remotely. I had one telehealth visit this morning with a stable hypertensive, and I knew he's otherwise healthy. He's monitoring his blood pressure. We can do fine by phone, but that's the exception, I think, sometimes. And so we're still having them come in. We're trying to keep them separate from the people who are being triaged with respiratory infection and getting them into the exam room as briskly as possible after it's been wiped down, and then sent back out as briskly as possible. But you're right, we can't do everything by phone.
That's entirely true. We have one more person that we haven't heard from. I want to know, is Trudy, was she able to get back on? Are you here? Trudy on the phone?
There she is.
Hi. Would you like to introduce yourself? You didn't get a chance to do that earlier. So would you like to introduce yourself and just tell us how things are going for you?
I think Trudy's still on mute. She says she'll be here in 1 minute.
There we go.
There she is. There you are. Thanks, Trudy. Yep.
I turned the video off because I kept getting kicked out, and anyway, so hopefully you can hear me. Sorry that I'm late. So I'm at the San Francisco Department of Public Health. We run 12 to 15, depending upon how you count, clinics in the city. Things are changing probably every half day, our protocols and what we learn and what we do. We've gone from, we were trying to follow, the CDC screening. We've gone from asking about travel history to probably not, but there's a now pretty lengthy like COVID screening that probably everybody's doing. I'm in one of the larger clinics. All of our clinics are different. The buildings were built in the 60s. I'm lucky to be in one of the larger ones, which with a very large open space initial sort of corridor and then a smaller waiting room. So what we piloted just today was actually dividing the clinic into two, and I was the COVID, sort of screener provider of the day. And any patient that walked in with any respiratory symptoms, whether they were on the schedule or they just walked in or the nurse advice line scheduled them in, we took them immediately to one of our 4 other rooms that's usually used by our PharmDs and our therapists and other providers. And we made those sort of our isolation rooms. And so then they were immediately masked and put in a room, and then I would talk to them by phone and do the history because we are low on PPE also. And then I would deem from that, low risk, high risk, and decide what PPE to put on. So this particular patient that I saw this morning was low risk, but we sort of ran it as a drill for if we had a high risk patient. We did have a high suspicion patient last Friday. That was our first one, and we swabbed him, and the test is still pending, so we'll see. But that's sort of why, that's what prompted us to sort of divide the clinic into 2. However, excuse me, we're really struggling with the same thing that you all are in terms of, we know that the people we're supposed to be keeping out of the clinic are the ones who are higher risk, either by age or by, their uncontrolled diabetes or CHF, but they're also exactly the patients we feel like we need to see. So we're kind of struggling with that. What we're doing is, as I typed up, like last week, we were offering telephone visits, and this week we're pretty much saying, you will have a telephone visit unless the doctor deems that you need to be seen in person. And we were getting a lot of pushback Monday morning until the shelter in place order came in. And so once that happened, I think it freaked people out enough. But prior to that, we were getting all kinds of people who did not need to be in clinic, who are high risk in clinic, patients with cancer, patients who are over 80, that kind of thing. So we're just trying to keep them safe, and it's been a struggle. The testing situation has changed quite rapidly. We've gone from, if you have a patient, isolate them, call the Department of Public Health, and someone will eventually come and swab them, to forget it, guys, swab them yourself. And initially we were only supposed to swab high suspicion patients, and now they've kind of backed off from that. But we also know that there's not going to be enough tests to swab everybody as the crest rises. So we're trying to just be judicious about that. I'm seeing your questions about well child care. So today we're trying to follow what our pediatric clinics at San Francisco General Hospital do, but also kind of, case by case basis as well. We decided, or we're toying with the idea, if we are truly able to divide the clinic in half and have those with respiratory symptoms on one side and all the other patients on the other, we still right now are seeing at least children under 2 because we think those vaccines are important. And then any kids who need catch-up vaccines right now we're seeing. And then prenatals, we're trying to space out a bit. We're trying to see them when they need labs and when they need, their Tdap and GBS testing and stuff like that. But we're just trying to space them out. So that's sort of the answer. Our patients drop in a lot. So we don't have always a lot of control. We have a high no-show rate, et cetera. So I think we're just doing the best we can to try to keep our patients safe. So that's where we are right now.
Thank you so much. That's a really good overview, and I love that you're sort of thinking through the whole well child care sort of scheme of things. How about everybody else? What are you doing with your preventive care? Are you trying to sort of eke it out for later on? I have a message here from Simona. I see that she's saying that she's seeing infants first thing in the morning in dedicated well rooms. And I know that a lot of people have told me that they're seeing their sickest patients, the people that they're thinking are risky, at the end of the day rather than at the beginning of the day.
Yeah, I liked Jeff's answer to one of the previous questions was it depends on the day. So things do continue to evolve. I think, if anything, there's sort of this interesting necessity for all of us to become, for lack of a better way of putting it, physicianeers. We have to think about how to engineer the workflows so that we can meet changing demands, right? And, you know, a week ago, we were operating very differently than we are today. We're actually going to operate very differently tomorrow because of the lockdown from Orange County. So, you know, part of what we've done to gather that data is effectively set up some morning meetings where we have some key performance indicators that come from the clinics that we roll up to leadership. And then we use that data then to decide how we're going to distribute resources over time. There's sort of the physical resources like PPE and you know, other equipment, but there's also staffing. And someone had mentioned earlier just the fear that staff can have, you know, and start to freak out. You know, we do also have dental on site. So ADA and CDA have both come out to say that they strongly recommend not coming in for non-essential, non-urgent care. So we've tried to figure out ways to utilize, be available for patients, yet at the same time, we have to leverage the staff that are on payroll, you know, to have them be productive. And the messaging from leadership has really been, you know, all hands on deck. We may be asking you to do things that were a little bit out of your comfort zone, but it's really key that you chip in. So, you know, I think to go back to the original question, sorry, I went off on a tangent there. Really, it's looking at like combing your schedule, trying to figure out how best to meet needs on any given day, and it really depends on that demand and supply. And I think that's gonna change every day, or you know, even sometimes even in a half day. So I think keeping your pulse on it as you know, a leader in your community is going to be a really key piece of this.
I love that. We are physicianeers. That has to go viral. That's just awesome. I love it, Jay. And truly, your advocacy in all of this is just like amazing. I just love it. I have here a slide on social media. I hope everyone can see. And, you know, I think that it's times like this. I mean, you all know that I love social media, and Jay loves social media. Many of us here love social media, but even more so that we need to amplify this message of what we're doing as family physicians on the front lines. Many of you who are right there seeing patients every single day. And we need to let everybody know, you know, what it is that we're doing. I'm hearing from physicians all over who are really struggling. And it's not just the fact that they may not have PPE, but how are they going to make payroll? If they don't see patients, how are they going to take care of their own families if they get sick? And lots of different things, but we can really amplify all of these messages if we get the message out. So this is my ask, is just that all of us really do reach out on social media and retweet AAFP and Sean Martin and Jay and all of us here to really get the message out. I think it's amazing. It's wonderful news, Julie, that Doug will be meeting with our VP tomorrow, and that is just amazing advocacy on AFP's part. I wanted to go through some of these questions that we have here and some of the comments. And
Kim, I had a question that I asked earlier. Maybe you didn't see it. So going back to my original question, so if someone is suspected to be positive for the COVID-19, and it comes to like a group home, is the current recommendation to quarantine the entire group home, or what are the recommendations given out? They're not positive yet, but they're highly suspected to be. What is the necessary precautions to be taken at the group home?
Would anyone like to answer that?
Yeah, that's kind of what the public health department is doing. Thanks, guys.
I mean, if it's a group home, I think it depends on how many people are in the group home and whether they can, quarantine that person to a certain part of the group home where nobody, very few people have to interact with that person.
No, the person's in the hospital, but I'm just saying, for everyone else that was in the group home. What do I do now? Yeah.
Yeah. I would say, in a lot of ways, the experience that we've seen in Seattle around nursing homes is part of what made me very worried about 200 people in a warehouse, basically, which I would say translates to people being in a group home, potentially having been exposed, and we don't know what we don't know, right? And so, I would say, particularly in those cases, using your voice and your connections to try to secure some test kits. I think it's better to know than not know. Otherwise, with the R0 being 2, in just a few days, you could go from everyone being cool to an entire group home being impacted. And so, to the extent that you can get ahead of that and do the global testing, even if it's just for the members that live in that house, I think that's the right thing to do. You may not get it, but I think morally and ethically we have to try.
So you're saying to mass test everyone in the group home, even though we don't have a positive on this person?
Well, I would say if there was somebody that was hospitalized did you say that person, there was concern for symptoms, or?
She's a 50-some-year-old female with fever, cough, and shortness of breath. And she recently came in from a nearby city. So, in terms of triaging, she met a lot of the criteria. And she was sent via, I don't know why they sent her via ambulance, but they sent her via ambulance to the hospital to get tested. So the question that, was posed to me is, what do we do with everyone else in the home? So my recommendation at this point was to just limit people coming in, limit people going out. If someone comes in, they wear a mask. If someone comes, someone shouldn't be coming out, but let's just wait for the 3 or 5 days that it takes to get the testing back and take as much as, I just didn't know if there's something else I should be doing and totally put them on lockdown, because the public health department basically tells me, we don't know. And then the infectious disease specialist basically tells me, I don't know.
Yeah. I think I'm inclined to say that I think there would be benefit in at least raising that possibility of doing global testing for the people in that home, because of the high risk. Fever, cough, shortness of breath. Those are sort of the hallmark, presenting symptoms, right? And so unless that person had a flu test that was positive, which makes the likelihood of COVID infinitesimally small, I think until, depending on how that person was worked up, because of that uncertainty, if we had global testing, you would have tested everybody in the group home, right? We're saying, oh, we're not going to test because we have limited resources. So in order to go to that global testing, I think you're going to have to be loud. I worry about the patients that you're caring for, and I worry about you because you don't know.
No, I don't know.
So, yeah.
I'm
and I think short of that,
truly answered your question very well, Jasmine, but we'll be thinking of you and hoping everything works out there.
I'm about to run away.
Yeah, I know, right?
Don't run away. Don't run away.
Yeah, you can't run away because we have to trace you and track you and see. I've heard in other countries though that they do actually track people's location. Like for example, in Hong Kong, when you land in the airport, they give you a bracelet, and you are literally given 2 hours to get to your home. And they actually track you for 2 weeks to make sure that you stay, where you're supposed to be. So that they can really ensure that things don't spread, that you're not bringing stuff into the country. I'm not sure that we're ever going to get to that. But
anyone ideas.
yeah, I just found it really interesting how things are different in different parts of the world, and how, I think there's a lot that we can learn from globally from the physicians who are 10 days ahead of us, 11 days ahead of us in Italy or in Spain. There's much that we can learn from our global family medicine docs in Wonka. And so I can share some of that information as well. We have a question in here from Julie about what the AFB can do with helping our mental well-being as family docs during this COVID pandemic. And I see a lot of comments here about memes, that we need to consolidate funny COVID memes, which I know I've seen quite a few in our Facebook group, but how else are people managing it? I'm not a yoga person. Like if Reed Blackwelder was on this call, he'd be like, everyone should be doing yoga, but I can't do yoga. So I'm not going to even go there. But what all are you doing?
Well, I was going to, in response to Julie's question, what else can the AFP do?
Yeah, what can the AFP do?
My first reaction is keep advocating fiercely and keep communicating to everyone, all the members, as to what you're doing and what the responses are. I think there's a natural tendency to feel like you're in a bunker and the only people fighting this fight are the soldiers next to you. And to know, intellectually, I know that the AFP is on this, but really to hear that message over and over and hear what's going on and see what's going on, I think really helps bolster morale. And it's a great advertisement for why it's important to support the Academy, be part of the Academy. But I think it really does help people know that fighting is going on for us and our patients.
Amen that. Anyone else? I'll be honest with you. I was really glad that today I heard that AFP is going to be canceling not AFP, the ABFM is going to reschedule the board exams for those who have board exams this year. I took mine, so like last year, so I'm all good. But for those that were supposed to recertify this year, it probably will be moving till the fall, I guess, hopefully. So other things AFP can do. The Physician Health and Wellbeing Conference obviously was, has been postponed. And so I'm hoping that we'll have more resources available from some of the people who would have been speaking at that conference. I'm sure we'll be trying to hit up and do some webinars, right, Julie? We're going to try and get Vince and CME to let us have some of those resources. I love what Prasad said here. He said, someone from Sarah Jeffrey on Twitter said, your grandparents were called to war. You've been called to sit on your couch and you can do this quarantine life. Yes, and Jay's saying, Gen X has been preparing for this moment of social distancing our whole life since many of us were latchkey kids growing up. True, true. And when I look at my kids, they've been they're totally fine. I mean, they're in their rooms on their phones and talking to all their friends. So I don't think they feel like they're missing anything right now. They feel just as connected with their world as they were. And Shannon just drained her her muscles, so she's meditating. That's really funny. I do think collecting stories of physicians on the front lines is really important. And that's something that I'm sure many chapters would love to do, is to really share the stories that we're hearing from our physicians. So that's definitely something that we could do.
Kim, one other thing I was reflecting on, if I could, is, and we talked about how we've been training our whole lives for this, and this is our moment to serve and to shine. But another important thing to remember is the impact we have on those around us, and nursing staff, front office staff, medical students, our patients, how they see us respond and how we carry ourselves has a tremendous impact on what they're able to do to get through the day. So it's an extra little burden when we're already pretty stretched, but just being aware that how we carry ourselves has incredible impact on those around us is another responsibility we shoulder.
Absolutely, Jeff. We are in such a privileged time and moment. It's really quite remarkable. I keep sort of rubbing my eyes, trying to wake up and hoping that this is just a dream. But as leaders in our communities, we have to really reach out and be there and to be present. I think it's important that we do take time to take care of ourselves. I know you guys. I know Family Docs really well. And we pour out our souls and our hearts. And every single one of you, every single day, I know you're giving 300% of your time and 300% of your heart. But please take care of yourselves, because we only have you. And if you're not there, who will take care of America? So I just want to say thank you to each and every one of you. Any last thoughts? We have a few moments, so I don't want to take all of the last moments, but I just wanted to say thank you to each and every one of you for being on this panel, and also to everyone out there who's listening and who will listen. Thank you so much for what you're doing every single day. You're amazing. I love you. Keep rocking on.
I just wanted to say, I wanted to reiterate what you were saying, Jeff. A lot of people are looking at us right now. A lot of people are looking at us for answers. We need to be calm, collected. Also, at the same time, we need to be united in our voice that this is a problem. I mean, I think for the first 3 or 4 days of this, everyone was like, whatever, it's not a big deal. And now we're realizing, oh no, it is a big deal. So I think, making people understand that it is still a big deal. It is going to be a big deal, but being calm and collected and leading with grace and leading by example is what we need to be doing, and being united. And I think we're doing a good job at doing that. We're doing this, right? So
yeah.
Exactly. Him for organizing this. It's important. And I think in the next 2 days, and I'm seeing it already in Taft, people are breaking down, especially with this new announcement that kids are going to be, especially, I don't know what it is about having your kids at home for 3 months, but especially with this announcement that just went out, I have a lot of parents that are like, oh my God, I cannot have my kids at home for 3 months. So a lot of people are going to be breaking down. And I'm seeing it in the clinic already. And I think we need to do our best at this point to make people realize that nothing's permanent. Things are changing second to second. There's some things changed a second ago, some things are changing a second ago. So let's get through these next 2 weeks before we make any final judgment calls, before we try to say, oh, our life is over, we're going to be isolated forever. No, let's get through these next 2 weeks. Let's see where we are. There's no point in jumping to any conclusions at this point. So really trying, that's what I'm doing to hit home to my patients right now is it's temporary. Nothing's permanent. Let's just get through this minute.
Thanks so much. Great way to end it. We're going to get through this together. Rock on, FM Revolution, washing hands while we're doing it. Take care, everyone.
Thank you all so much. Thank you, panelists, and thank everyone on the phone for being with us tonight when you could have been with family and friends or sitting in a room quietly by yourself. We really appreciate the time and the effort and the commitment you've given to all of your patients and to us. Good night.
Good night.
Good night.
Good night.